So guys, today we are going to see 10 marks important question, that is epistaxis. Okay, it is a 10 mark and most repeated question. Okay, what is epistaxis? It is bleeding from the inside of the nose, seen in all the age groups, present as emergency. It is a sign, not a disease. Okay, what is the blood supply of the nose? First of all, we will cover blood supply of the nose only. Okay, so here is a beautiful diagram given in our textbook only. Here see, internal carotid artery gives rise to ophthalmic artery, which gives rise to anterior ethmoidal and posterior ethmoidal artery. Okay, anterior ethmoidal artery supplies anterior superior part, posterior ethmoidal artery supplies posterior superior part. Okay, now from the below, from external carotid artery, it gives two branches. One is facial artery, another one is maxillary artery. Okay, facial artery continues superior labial artery and its septal branch. Okay, and another maxillary artery gives rise to two branches, that is greater palatine artery and branches of sphenopalatine artery. Okay, this facial artery gives rise to septal branch, forms a part of Kessel's plexus. Next is maxillary artery, gives rise to two branches, that is greater palatine artery and sphenopalatine artery. Okay, this greater palatine artery and facial septal branch of facial artery from the anterior inferior part, and sphenopalatine artery rise from the posterior inferior part. Okay. One more important thing is this Kessel's plexus. Okay, it is present in near the vestibular region and it is formed by the four arteries. Okay, one is anterior ethmoidal artery, septal branch of facial artery, greater palatine artery, and sphenopalatine artery. Only artery which is not take part in Kessel's plexus is posterior ethmoidal artery, which not take part in a Little's area. Okay. The most common artery to get bleed is sphenopalatine artery. Next, one more thing. Blood supply of the lateral wall of the nose. Okay, the one which I have told, this is blood supply of medial wall of the nose. This is lateral wall of the nose. It is also the same. Okay, internal carotid artery gives rise to ophthalmic artery and ophthalmic artery, which gives rise to anterior ethmoidal and posterior ethmoidal. Same thing. Okay, but in below, external carotid artery, facial artery, branches of facial artery this side. But here maxillary artery gives rise to three arteries, that is greater palatine artery and lesser palatine artery. Okay, this one is extra, lesser palatine artery. Another one is sphenopalatine artery. It is same. Okay, this was the blood supply. Now we will read Little's area. Okay, Little's area. It is a 3 marks question, situated in the anterior inferior part of the nasal septum, just above the vestibule. Okay, which Little's area is also known as Kessel's plexus. It is formed by anterior ethmoidal artery, sphenopalatine artery, septal branch of greater palatine artery, and septal branch of superior labial artery. Okay, caused due to exposed to drying effect of the inspiratory current, fingernail trauma seen in the children and young adults, site of origin for bleeding polyp or hemangioma. Okay, next is retrocolumnar vein. Vein runs vertically downwards behind the columella, crosses floor of the nose, joins venous plexus on the lateral wall of the lateral wall. Common set of bleed in young people. Okay, retrocolumnar vein, common set of bleeding in young people. Woodruff's plexus. Okay, Woodruff's plexus is a venous plexus present behind the Kessel's plexus. Okay, it's the posterior end. Venous plexus present inferior to the posterior end of the inferior turbinate. Okay, side to the posterior epistaxis in adult. Anterior epistaxis is by Kessel's plexus. Posterior is by Woodruff's plexus. Now, what are the common for epistaxis? Okay, common causes for epistaxis. Epistaxis shows bimodal age group. One most commonly in children, that is because of trauma, nose pricking. Upper respiratory tract infection causes dryness. Foreign body presentation, unilateral foul smelling discharge. In adults, most common causes in adults are idiopathic and hypertension. Okay, it shows bimodal age group. In children, it is because of trauma, URTI, foreign body. In adults, it is because of hypertension. Okay. Other causes are surgical trauma, that is septoplasty, FES, that is functional endoscopic sinus surgery. Other is deviated nasal septum. Infections, that is granulomatous infections like infections and rhinosporidiasis. Tumors, young male or recurrent epistaxis, that is angiofibroma. Okay, angiofibroma, it is a bleeding type of tumor, benign tumor. Drugs like nasal decongestant, xylometazoline, oxymetazoline, steroid nasal sprays. Next is systemic causes like platelet disorder. Okay, the disorder of primary hemostasis, thrombocytopenia, decreased production of platelet like leukemia, myelodysplastic syndrome, increased destruction of platelet like idiopathic thrombocytopenic purpura, which is splenomegaly. Drugs like antiplatelet like aspirin and NSAIDs, anticoagulant like heparin and warfarin. Improper function is improper function or dysfunction of von Willebrand disease. Okay, infections like dengue, hemorrhagic fever. Okay, all these are conditions in which platelets are defective. Okay, or platelets are defective or decreased or destructed. Okay, next, Disorders of second. Next, clotting factor abnormalities like liver disease, vitamin K deficiency, chronic alcoholics, hemophilia A and B, drugs like heparin and warfarin. Okay, all these are don't let the blood to coagulate. That's why there is a continuous bleeding, epistaxis. Okay, sites of epistaxis, most commonly 90% it is Little's area only. Little's area, already know Kesselbach specific Little's area. Above the level of middle turbinate, it's from the anterior and posterior ethmoidal vessels. Okay, from the internal carotid artery. Okay, I already said medial wall of the nasal septum divided into 4 parts like this. Okay, anterior ethmoidal artery, posterior ethmoidal artery. From here, facial artery, superior labial artery, sphenopalatine and greater palatine artery come like this. Okay, like you should understand. Below the level of middle turbinate from the sphenopalatine artery may be hidden lying lateral to the middle turbinate or inferior turbinate. May acquire packing to control it. Packing I will tell. Posterior part of the nasal cavity, blood flows directly into the pharynx. Okay, if if bleeding is posteriorly, it directly flows into the pharynx. Okay, and you might aspirate the blood. Diffuse blood from both the septum and lateral wall. Most commonly is seen in general systemic disorders and blood dyscariasis. Okay, another one in nasopharynx. These are the sites. These are sites like from Little's area, above the level of middle turbinate, below the level of middle turbinate, posterior part of the nasal cavity, and diffuse nasopharynx. Okay. Now one classification is there. Let me show you. Okay, this is given in book only. Anterior epistaxis. Just read like this. Anterior epistaxis incidence is more common. Mostly it is from the Little's area only. Next, mostly occurs in children and young adults. Cause is most commonly it is because of trauma. Okay, bleeding is usually mild and can be controlled by local pressure and anterior nasal packing. Okay. Another is posterior epistaxis. It is less common. Okay, mostly from the posterior part of the nasal cavity, often difficult to localize the bleeding. Okay, as it is located more posteriorly, you cannot localize the artery. Okay, after the age of 40 years of age, mostly because of hypertension, it is spontaneous, often due to hypertension and arteriosclerosis. Bleeding is severe, requires hospitalization and postnasal packing often required. Okay, this is difference between anterior epistaxis and posterior epistaxis. Have a look. Okay. Now coming to management. Okay, most importantly they will ask management only. How will you manage the epistaxis case? First we will do history taking. Okay, we will ask the patient like what is the mode of onset, it is spontaneous or fingernail trauma is present, what is the duration and frequency of bleeding, what is the amount of blood loss, and side of the nose from which the blood loss occurred, like from right side or left side, it is from anterior or posterior type of bleed. Known bleeding tendency in the patient, like any family members have same thing, like history of a medical ailment like hypertension, leukemia, mitral valve stenosis and cirrhosis, or liver disease. Okay, history of drug intake like analgesics and anticoagulants. We should ask all this, then we will get some history like how to treat. Next, this is the flow chart. Okay, most important. First, whenever there is epistaxis, first we will try to do first aid. Okay, by nasal pinching. It is also known as Stotter's method. Okay, the nose and bend anteriorly. Next we will do nasal decongestion like xylometazoline and oxymetazoline. Next we will do cauterization. Okay, cauterization of the artery. If still epistaxis continues, we will do anterior nasal packing, and if still it is continuous, we will do posterior nasal packing. Okay, and later we will do endoscopic cauterization and elevation of the mucopericardial flap and by submucosal resection operation. Okay, we will find the artery and we will ligate it or cauterize it. Okay, ligation of the vessels, that is sphenopalatine artery, maxillary artery, extracarotid artery, anterior and posterior ethmoidal arteries. Okay, another one is TESPAL. Okay, TESPAL is nothing but transnasal endoscopic sphenopalatine artery ligation. Transnasal endoscopic sphenopalatine artery ligation. Another one is the embolization. Okay, these are the things we should do whenever there is epistaxis. Okay, first aid, nasal decongestion, cauterization, anternasal packing, posterior nasal packing, elevation of mucopericardial flap and submucosal resection operation, ligation of the vessels, TESPAL and embolization. Now same things we will explain it here. Okay, first take the general measure, make the patient sit up and back rest and record any blood loss through the spitting or vomiting. Okay, reassure the patient, mild sedation is given. Check for pulse, BP and respiration. Maintain hemodynamics. Blood transfusion may require. Okay, so keep the blood pack ready. Antibiotics to prevent sinusitis. Pack kept greater than 24 hours. Next, intermittent oxygen should be given as there is bilateral packed nose. Okay, if the both the nostrils are closed, the way should breathe. That's why we will give 100% oxygen for some time. Okay, investigation and treatment of local and general underlying cause. First, coming to first aid. Okay. Now this first aid is like a general reading is there, so read with me. Patient bleeds on the little's area. Pinch the nose with the thumb and index finger for 5 minutes. Compress the vessels on the little's area. Okay, this is known as Trotter's method or Hippocratic method. Okay, we should pinch the area with the thumb and index finger for 5 minutes. Patient made to sit by leaning little forward. Okay, over the patient. Pinch the nose tightly. And cold compression should be given because cold compression causes reflex vasoconstriction of the vessels. Next is the cauterization. Okay, it is useful in anterior epistaxis. Cauterization is used in anterior epistaxis to localize the bleeding point. Bleeding area we will give topical anesthetic and cauterize. Okay, by bipolar cautery or local silver nitrate AgNO3, silver nitrate cautery. Okay, if there is anterior epistaxis, we should locate the site of bleed and we should cauterize it. Next, anterior nasal packing. Okay, anterior nasal packing, there is active anterior epistaxis, nose cleared of the clots and suction, bleeding site is localized. Okay, minor bleed we will cauterize it. If profuse bleeding we will do anterior nasal packing. Okay, for that we will take a ribbon gauze of 1 meter length, 2.5 centimeter width for adult and 12 mm width for children. Okay, soaked in liquid paraffin. Okay, soaked in liquid paraffin, required for each nasal cavity. Okay, first few centimeters of the gauze are folded upon itself and inserted along the floor of the roof. It is horizontal layers. Inserted along the back and front, it is called a vertical layers. Okay, let me show you the diagram. And whole of the nasal cavity is tightly packed. Then both the cavities need to be blocked or packed. Remove for then removed after 24 hours if bleeding stops, or 2 to 3 days after. Okay, in this case systemic antibiotics is given to prevent sinus infection and toxic shock syndrome. Okay, we will put that nasal packing and leave it there for 24 hours. Then we will remove. We will see like bleeding has stopped or not. Okay, otherwise we will keep it there for 2 to 3 days. Then we will see if our bleeding has stopped, and we will use antibiotics also. Okay, otherwise there is infection. This is two types of intranasal packing. Okay, it is in vertical layers and it is in horizontal layers. Okay, now what is posterior nasal packing? Okay, posterior nasal packing for posterior bleeding posteriorly into the throat. Okay, there is bleeding posteriorly. A piece of gauze is rolled into a shape of a cone. Piece of gauze rolled into a shape of a cone. Three silk threads are tied to it in the posterior nasal pack. Okay, rubber catheter is passed from nose to the mouth. Silk thread are tied to it. Okay, and a catheter pulled backward and drawn from it. Pack followed by the silk thread and guided into it. Nasopharynx with the index finger. Okay, let me show you the diagram. You will understand. Okay, this is the technique for posterior nasal packing. Okay, first we will put a rubber and we will take it out from a mouth. Okay, to the rubber end we will tie a gauze. Okay, and gauze has 3 threads. 1, 2, and 3 threads. Okay, and we will pull this rubber tube outside. Okay, so that this gauze comes and sits here, and one of the thread is cut and let it to hang in the oropharynx. Okay, other 2 are tied outside here. Okay, this vertical anterior nasal packing is continued. I hope you understand. Okay, while removing, no, first they will cut here and they will remove this. 2 threads are remaining. Okay, then they will hold this thing and pull it from the out. Okay, they can remove it. I hope you got it. Okay, posterior nasal packing. The nasal pack is done. 2 threads tied over the dental roll. Third thread is cut and short allowed to hang in the oropharynx. Okay, easy to remove after pack later. Patient always hospitalized. Patient is always hospitalized. Foley's catheter. Another one is a Foley's catheter of size 12 to 14 size can be used. Okay. After insertion, balloon is inflamed with 5 to 10 ml saline. Pulled forward for the coina is blocked. Okay, anterior nasal packing is done. Nasal balloons are also available. Has 2 bulbs. Okay, let me show you that diagram also. Okay, this is a balloon. Okay, this is A and B. So this is Foley's catheter used. You can read here downside. Okay, in A they have used 10% saline. Okay, and in B 30 ml. Okay, 10 ml and 30 ml. Balloon for posterior epistaxis balloon. Nowadays they are using this. Next, endoscopic cauterization. Topical or general anesthesia is given. Bleeding point is localized with a rigid endoscope, and with bipolar cautery we will cauterize the bleeding site. Okay, there is decreased morbidity and hospitalization stay is ensured. Okay, limitation is profuse blood, no localization of the blood area. Okay, if there is profuse bleeding, you can't localize from where the bleeding is. Okay, that's why it's difficult. Next, elevation of the mucopericardial flap and submucosal resection operation. Okay, In this case, persistent recurrent bleed from the septum, mucoperiocondylar flap is elevated and the reposition back, okay, causes fibrosis and constriction of the blood vessel. Submucosal resection operation, remove the spur and same about the result, okay. We will do SMR operation, the blood vessels get fibrosed, okay. Next, ligation of the vessels, okay. We will ligate maxillary artery, external carotid artery, anterior and posterior ethmoidal artery and sphenopalatine artery, okay. In maxillary artery, uncontrolled epistaxis is present. They will do Cadwell-Lux approach, okay. Ligation is sphenopalatine fossa by the clips. Maxillary artery is ligated in the sphenopalatine fossa. External carotid artery, when the conservative measures fail, ligation is in the neck or above the superior thyroid branch, okay, to prevent the retrograde systemic thrombosis for external carotid artery. Next, for anterior and posterior ethmoidal arteries, at the adjoint of sphenopalatine artery, uncontrolled anterior superior bleed above the middle terminate. Link Howarth incision is used, okay. Link Howarth incision is used for anterior and posterior ethmoidal artery, okay. Now coming to TESPAL, okay. Here we will ligate sphenopalatine artery, okay. Here the rigid endoscopy is used under topical anesthesia and with sedation and general anesthesia. Mucosal flap in the posterior part of the lateral nasal wall is elevated. In the sphenopalatine foramen we will get sphenopalatine artery, okay, exits closed with the vascular clips, okay. A high success to control the refractory posterior bleed, okay. Bleeding will stop a maximum amount. Another one is the embolization, okay. Embolization is done with the interventional radiologist, okay. Next, through the femoral artery catheterization. Femoral artery catheterization, we will do embolization, okay. Internal maxillary artery, we will localize it, and embolization with the absorbable gel foam or PV alcohol or coils are used, okay. Unilateral epistaxis, bilateral or ipsilateral or bilateral epistaxis due to cross circulation. It is a safe procedure. Risk of a cerebral thromboembolism is there, hematoma at the local site, okay. Ethmoidal arteries cannot be embolized, okay. Anterior and posterior ethmoidal arteries cannot be embolized by here, okay. That's it, guys. This was epistaxis, and it is a 10 marks important question. I hope you have understood everything. If anything, let me know in the comment section, and please subscribe Medicommand YouTube channel. See you in the next video. Until then, Jai Hind, Jai Bharat. Bye bye.